Whenever you talk about the technology in knee replacement, you want to know about precision, advantages, harms, cost, complexity, and ethical concerns. And particularly about the last one, as you might have heard that in Australia, they have banned advertising for robots. That has been banned now. So, but on the other hand, if you don't adopt a new technology, you are actually depriving the patient of a meaningful technical advance. So, we have to take a very balanced view, and that's what I thought I'm going to do today. There is an exponential increase in the expected arthroplasty, and the technology has evolved along with this. And we know the problems of the conventional TKR. Everybody will tell you about that. 20% dissatisfaction rate cannot be reproduced. You gap balancing and alignment are not quantified. You cannot fine tune sections. There's error with saw blade, no feedback, etc., etc. So there has been an increasing use of the technology because of that. The one graph here is the robot. This is navigation, and this is the cumulative. So you can see that the use of navigation as well as robotics is on the rise. So ever since the first robot was introduced in 2006, and from there, now in 2021, there were actually more than 1,100 Mako systems in US alone. So you can see how more and more companies have been launching their robots. So it is something like nobody wants to miss the bus. And of course, it's for total knee, total hip, and partial knee. So this is a very important slide, which is because this is about the patient perception. These are the Google search which the patients are undertaking, and they are on the rise. More and more patients want to know about what is happening in the robotic, and that is something pushing it. So this is a slide which tells you why we are having this conference here, because Maharashtra is on top when it comes to the who's looking for our technology, and then Punjab and Delhi closer to home, and then down south Telangana and Karnataka. These are the 5 states which spearhead where the patients are looking for the robotic technology. And the only purpose is alignment, and that has been said many times. So I'll talk more about it again. So there's greater accuracy, more precision, less dependence on surgeon experience. Now, imagine me talking about it, where only thing I have to tell the patient is that I'm a very experienced surgeon. And you talk about that getting rid of the experience. But then we'll talk more about it also, but more reproducible. So we know what happens when a knee is malaligned. There's no question about it, although there are, the definition of malalignment. But we believe that all these things happen because he is malaligned, and all these things happen when the hip is malaligned. So that is the basic argument on which the adaptation of technology is based. But when you talk about innovation in orthopedic surgery, it has to be evidence-based. So what we are looking for is actually the proof for accuracy, soft tissue protection, learning curve, and outcome. So let's address this. This is my favorite movie. So let's talk about what is the good about the robot. So the good things about robot are precise planning, intraoperative feedback, and precise bone preparation. We all know that it is really, you get what you want, and that's why it was emphasized. Krishna said that you must know what you want. They say that you must be careful about what you wish, it might be granted. So if you plan it wrong, then there's going to be a disaster. And then of course, this is not about the fully automatic or fully active robot, but most of the times you have a feeling that you are doing something, and you got the haptic control, and you can feel that the things are not really out of your control. As a surgeon, you have to have that feeling of being in control. It gives you enhanced planning. Like Krishna said, you can just look around, you can manipulate the implant on the key fragments, you can look at everything, dynamic joint balancing, you can make all adjustment, balancing, flexion, extension, you can prepare the bone, they're stereotactic, you would see that as you start, milling or burring or whatever you want to do, these all green areas disappear. So you know that you have done the complete job. And that would be not vary by more than, less than a millimeter and all. And then we know that there are short-term clinical benefits. That means the periarticular soft tissue preservation. Patients have less post-operative pain, less need for analgesia, decreased physical therapy duration. And then, of course, the medial soft tissue injury was reduced in correctable as well as fixed deformities, and then you could have more accurate femoral and tibial cuts. And something called the macroscopic soft tissue injury was also less. These are the advantages. So if you are somebody who believes in this, I think the bicruciate retaining is the kind of joint where even a non-believer should actually resort to robot, learn it and do it, because that's something really, see, when you do in general surgery, one of the advantages of robot is robot can reach where you cannot reach, or where your instruments cannot reach. So this is, I think, one such example in orthopedics. We want to do bicruciate retaining, maybe this is a good idea. And then, of course, the outliers, gap balance, everything has been mentioned that they are the advantages. However, without any difference in clinical scores or complications when compared to conventional. So we are building a story. Of course, in total hip, it has got the advantage of 3D templating and intra-op guidance. So I've tried my hand, and I can tell you this is, I have done navigated hip replacement also. Not very different exactly, but then it's actually haptic tool or really reaming, and without any risk of overdoing it, which you can do when you are doing navigated, because then it is, you are reaming and checking where it is going, but then it's of course more control. And this is the component position, a tabular position in this paper and in this paper, that, you know, outliers are less and your component positioning is very good. One more add-on for NACO, as they are saying, is that they can take into account the spinopelvic deformities, and they can actually plan and let you know where to put your cuff, which can really be a big value addition. So how should we evaluate the robotics in the operation theater? So let's talk about the learning curve. Most papers put it around 6 to 20 cases of TKR, and surprisingly, the literature has pegged the UK a little higher, 6 to 36 cases. And everybody agrees that the stress level is highest in the first 6 cases. Now, this was a paper where 16 inexperienced surgeons were randomized to perform UKR, and they were, whether they were with conventional or with robotic, and they found that the implant positioning was better with the robotic. They had no experience of doing UKR. They did it with robot or without robot, and they were much better when they did with robot, even in initial cases. So it's a great tool for teaching and training. Another paper last year, Journal of Arthroplasty, robotic assisted totally allows for trainee involvement and teaching without increase in operating time. So, you know, if they learn it early, they can take independent decisions much earlier. So that means if you're trained on robot, you become very slick at managing the gaps and planning on the robot. And planning is most important. Like we always say, when you do robotic surgery, you plan twice and execute once. So there's always another chance. Now, another paper about hip arthroplasty, whether it can mitigate the learning curve. They took, you know, the two groups, the newly graduated orthopedic surgeons and the experienced orthopedic surgeons, 60 cases each, 30 direct anterior, 30 posterior approach, no difference. So it is a substitute for experience, if you like I said right in the beginning. So do away with the experienced surgeon and do it with the computer. But then another advantage which is not mentioned, because we're still talking about the good, which is the ergonomic safety. So it has been shown that the physical and mental demand particularly during hip arthroplasty is very high. And I was surprised to see this figure, 300 mallet swings per THA. So last time I did a total hip, I started counting how many times I have to take a swing. But this is repetitive physical labor. 96% surgeons are reported to have musculoskeletal pain, low back, neck, hands, and the energy expenditure is equivalent to moderate exercise. So when you use it daily, you can have mental wellness, which has been reported. So stress of intraoperative decision making is less. There's effect of fatigue on cognitive and psychomotor skills is less. Complications when you are stressed, there'll be more fatigue, more cognitive and psychomotor skills with conventional thing, more complications, more surgical errors and burnout. So this is a paper which said that total knee arthroplasty with robotic surgical assistance causes less physical strain and stress than conventional methods. So another advantage. I'll tell you why I'm saying all this, because maybe when we talk about alignment, we are shooting at the wrong target. Now, there was longer operative time in the robotic group. Still, it was less strenuous as compared to the conventional. considering the basic energy consumption and the basal metabolic parameters. There were less rotatory movements at the neck lumbar spine in static and demanding position. And then, of course, there's an advantage of the artificial intelligence. And this is what it happens. You are actually gathering all the data, and then that data has a potential for integration using artificial intelligence on the deformity patterns, treatment protocol, and long-term outcomes. So if a patient does well, you can go back and see what kind of deformity was there, what kind of planning was done, and work, and vice versa. Somebody is not doing well, you can go back and see what did not work in what type of deformity. So once you have, say, 100 million or a million cases, 100 million is too much, but you have 100,000 or a million cases, maybe the AI itself will tell you that there'll be a prompt on the robot. The moment you chart the deformity, it will say, okay, this is the way to go. Just put your implants in these positions. So that's the future. Now coming to the bad. Now the bad is that it does not predict a good outcome, that has been mentioned. So it cannot guarantee, this word was also used by Nilen, doesn't guarantee excellent pain relief. And the other factors are not considered, like patient expectations and mental status. Clinical outcomes, lot of studies to say no difference in terms of functional scores, aseptic loosening, survivorship, and complications. It improves positioning and alignment according to this paper in CASTA and 2022, but is inconclusive on whether it improves clinical scores or reduces complications and revisions. So no difference in clinical outcomes at 3 months, cost neutral for hospital at 200 cases per year. That's why I asked, if you are doing more than 200 in a year, only then it is cost effective for you. Otherwise, we are actually spending too much on robot. This is what the literature says. And unfortunately, the superior radiological outcomes don't translate into better patient satisfaction. Now, this is something which is another paper which compared unicompartmental knee arthroplasty, equivalent results with robotic versus non-robotic. Again, bicompartmental, which I said, the bicruciate retaining knee replacement, maybe you are equivalent to achieving a biphasic gait as compared to a conventional one. Another paper, robotic assisted versus conventional, 10 systemic reviews, 3 RCTs, 72 studies, short term in 3 years, no benefits at 10 years, cost effectiveness is dependent on the volume, learning curve 7, and quicker discharge and higher surgical time. Those are the things. The next thing is from bench to bedside. So basically robotics and navigation, there's a question which is being asked. It is just the rise of the machines or just the rising costs. So let's talk about the cost. The systems are at least $1 million, probably $100,000 a year to maintain. And the cost saving is in terms of decreased hospital stay, shorter recovery period, and less follow-up visits. But that by itself is not enough to offset the cost. That's what you have to remember. It's somehow stuck. Can you help? It's just stuck. So, want to sleep. When it comes to money, so this is another paper which said the robotic assisted UKR, you have to do at least 94 cases in a year with a failure rate less than 1.2% for it to be cost effective. So these numbers are very important. Otherwise, you are actually spending too much and you are not recovering the cost of your your robot. So this paper said that you can save cost by, the less episodes of care. So they looked at how frequently patient had to come 0, 30, 60, 90 days. So the saving was when half the cases at least were done by robot. So again, more than 200, half of them robotic. Those are the figures which you need to offset the cost. And this again said, the reduced episodes of care cost and 90 days readmission rate is lower, shorter length of stay, higher rates of discharge to home. Those are advantages at that cost which I told you. So this another cost analysis said that, most of the cases, most of the studies which say they are comparable, they don't look into the upfront cost. If you look at the upfront cost of setting up the robot, it's much more expensive. Now coming back to the ugly. Now, when you are using robots, you have significant setup and maintenance cost. It is restricted to specific implants. So if you don't like the implant, you are stuck with it. the additional cost for imaging and manpower for interpretation, precision for pin, fracture, pin track infection. This is a real problem. OT space to store the equipment, and all systems are not the same or comparable. Again, learning curve of 70-20 cases. So that is also part of the drawback. And there is, of course, no learning curve for planned or achieved alignment, because some people might have difficulty. But this is an interesting study which said that robotic total knees needed more manipulation and anesthesia. They were getting less movement. So there is something going on there which we need to be looked at again by the data analysis, whether the rotations are going wrong or what is happening. The other thing is that online there is low health literacy among patients. So the pressure from patients builds up because patients surf online, and that is something called online research. There's a direct to consumer marketing which has been banned in Australia. So you can actually tell the patient that, get it done by robot, that is good. There are unverified claims of reputation and skill, misrepresented treatment benefits, non-specification of industry ties. That's another important conflict of interest. Anecdotal experience is not validated evidence, and excellence is often by assertion. Now, this is actually another very important slide I need you to look at. So the innovation should be assessed in terms of potential conflict of interest. Follow-up of 2 years is not enough in joint replacement. Most of the papers are talking about 2 years follow-up. The complications are a problem. This is an old study, but tells you that it can kill or mime. Remember that. And then, of course, this is all so much based on software that if you are wrong, like it was said, it can create havoc. And then, of course, there can be, this is in a lighter way. And the patient may say, why should you pay the surgeon when I'm paying for the robot? And then, of course, the author financial conflict. Look at this study. The patients who had conflict of interest, they had, $988,736 paid to them. This is the amount of money paid for this. And that's a lot of money. Payment per author was more than 139,000. So that is actually the problem of conflict of interest. Hello? Oh, it is ready. So I think I'll just summarize by saying what a robot can't do, but then I think you must see something which actually Charlie Chaplin, it was shown long time back. It's an interesting short video you should see. So this is where we were. So you must know what to do when the things go wrong, and you should also identify what is happening. So this is what happens in the theater. So, okay, go back and let's do over everything again. This has happened to us in navigation. It has happened to us in robot. What happens if the pin becomes loose in an osteoporotic bone and suddenly everything is haywire because everything is based on that. And then you have to go and do everything again. So again, you have to see when you're carrying a very expensive pen, you have to see, is it worth it? But then I have had always a philosophy that you should never endorse or condemn a thing unless you have done it yourself. So I have tried my hands on the different robots without actually buying one, because actually I have to spend your money in a government hospital to buy that. And I'm very careful with that. So this is one of the systems, Rosa in this case, which I used to actually ask them to give it to me for a month. I used it. So we operated on a total of 25 patients, 36 knees. 11 were bilateral, 14 were unilateral, 5 male, 20 female. Mean age was about 64. And out of these 14 unilateral, 2 came back for the other side after 6 weeks. The robot was gone, but they're very emphatic that they wanted it robotic only because they thought that the experience was very good, although they had nothing to compare it with. So best patient would have been the one who had, and again, it would be by recall, even if they had one conventional. But this is, if you see forgotten joint score, range of motion, pain, function, hip, knee, ankle axis, and surgical time, there was an increase of about 15 minutes on an average with Rosa. But we did indeed need less releases, and the patient did have less pain score, although nothing was statistically significant. So maybe the sample size was rather small. So it was surveyed. They asked the users, why do you use robot? So every user said, I use it for increased precision. But when they asked the non-users, they said, we are waiting for superior outcomes and marketing. So there are two kinds of people. There's one guy who wants to buy a new car, whichever luxury car is introduced in the market. He wants to buy it. He wants to be the first one to buy it because he wants to flaunt it. Other guy thinks that let a few people buy it, let a few thousand people buy it, and I'll know whether the carburetor has a problem or a silencer has a problem or something which goes wrong. And then I'll buy. It's your individual outlook. But Bob Booth says, never be the first surgeon and the last surgeon to be to operate on a procedure. Never be the first, never be the last. So best thing is somewhere in between. So this is very important. Early adopters were, an early majority of robotics was seen in surgeons with 6 to 10 years of practice. And very often, I mean, barring a few very experienced surgeons I know, and I was talking about this in the lunchtime, most of the people, you bought a robot and became robotic surgeon to be recognized as a knee replacement surgeon. And that is how fact is. It's a robot making them knee surgeon and making them famous. And this is what the literature says. 6 to 10 years of practice, you're still struggling to have a name as a knee replacement surgeon. You buy a robot and the company does it for you. So 200 knee replacement cake, 300 robotic knee replacement cake, and blah, blah, blah. So it goes out on the social media. The majority of these surgeons, as per literature, use it in only 20% cases. Because if you are really a high volume surgeon, the money you earn by doing robotic, by charging the patient, is actually less than if you could operate 2 more cases at the end of the day. So this is how it happens. So the reason they gave was complexity of case, comorbidity, consecutive cases and time. But this is the statistics, only 20%. And we have seen when the navigation came, it was parked in the corner in the theater. Surgeons were just charging and not doing it even by this. So that is another big problem. Unfortunately, here, everything which you do, the data gets logged on with the company. So, you can't bluff with the patient like this. So if you are doing robotic, the data has to go somewhere because that's the long-term plan to see what is happening to this. But this is actually, again, a very important principle. It's called Wald principle. It's Wald principle or adoption of robotic total knee arthroplasty is moving beyond radiographic alignment. So all the time we are saying outliers, this, I think that will always remain contested. You say, so what, you are shooting at the wrong target. Your target is wrong. You are accurate, but you are aiming for the wrong thing. So how you can still make use of the robot? So this is how it is. In World War, they saw that the planes which were returning largely had the bullet holes on the fuselage and the tail. So they thought that this is the area where the maximum bullets are hit. So let's try to fortify them. Till Wald, who was a mathematician, told them that they were actually being very stupid because it was the planes who were shot here, they were crashing and not coming back. So these were the ones who were being shot at and were able to come back. It's called survivorship bias. You saw it coming back, you said, oh, it has come back. Now it's got all the bullet holes. That's not where you need to concentrate. You didn't have any with hit here because those who were hit here crashed. So that's what you need to do. So change your focus. So that's something which is being talked about. So this is how it was changed, which was wrong. And then the Wald came with this, the survivorship. So look at what else robot can do for you. Because if you say less outliers, more focus, everybody will get up and say, no, I do classically, I do conventional, no problem, no difference in scores. Here what it does, you can enhance and stream the workflow. You can reduce work-related injury. It's also said for people like me who are now getting senior to aging surgeons, it can reduce your physical labor. You can still benefit from their experience without making them undergo vigorous physical activity, reducing pain medication, reducing the cost and the use of artificial intelligence. This is what is basically has been ignored. And that's where possibly most of the value of the robot lies. And this is something I'm very passionate about. So just see, this is about an active robot, right? A robot will beat you to everything which you do. So this is one of the best ads. So robot cannot enjoy what you can enjoy. So if you enjoy operating on your patient, then you will never accept a active kind of robot because it just keeps you away. So that if you get your adrenaline rushing by operating or being involved, so your work doesn't stop at, doing some maths on the screen. That's not the end of it. That a technician can also do. So this is, if you enjoy that, then this is the thing for you. So the take-home message is precise placement of component, clinical superiority is doubtful, but it reduces dependence on surgeon, higher cost and increased operative time, which may improve in future. But then, you know, the robots are like celebrity weddings. So they make it to page 3, you get it, it gets advertisement, you know, very expensive, but you show around and you say, okay, no, I have got this robot. But then, like what happened with the navigation, sometimes you see, if you look at the divorce rates, it's difficult to stick around sometimes, whether your numbers increase, whether you can carry on with that for very long is the question. Thank you very much for your attention.